frontline workers and need to be cared for and respected and protected for the incredible work that they do on the front lines, saving people's lives from COVID-19 and from many other infections. So all healthcare worker infections are important. Even one healthcare worker infection is too many. So we have some information on healthcare worker infections by country, and it varies quite, it's variable, highly variable by country. And from the data that we have that's received through our clinical platform, through our case report forms that come in, by country, it's anywhere between 8 and 27% of the reported cases. From data from our regional offices, this week, our regional director of PAHO noted more than 570,000 health worker infections in North and South America. And in the U.S. and Mexico, healthcare workers account for about 14% of infections. Across our African region, it's around 5% that are healthcare worker infections. And if you look across the published studies, again, the data is highly variable. And if you look at seropositivity, which is evidence of infection through antibodies, healthcare worker infection ranges from 1.6% to over 31%, depending on the study. And if we look at PCR testing by study, it ranges from 0.4% to over 23%. And so what we understand about how health workers are getting infected, there are several studies that are looking at this, and we have a living systematic review that we are conducting where we are constantly looking at the literature. And some of the reasons why health workers are infected is because of a lack of PPE, not having adequate PPE to do their jobs, and in some situations not having the training to wear the PPE appropriately. And early on in the pandemic, when we have cases in some different wards, such as geriatric wards or other wards that weren't prepared for droplet and contact precautions for infectious diseases, they weren't trained to wear the right type of PPE. That has been changed, and that has been improving. We also know that health workers are infected while on the job, when they're in rest areas, if between each other, so there's transmission that's happening between health workers. And we know that there are conditions in which they are working in where there's extended shifts, not adequate rest periods, that really needs to be supported. But we also need to remember that health workers are people too, and they live their lives. And unfortunately, many health workers are also infected outside of the healthcare facility. So I think there's a number of things that we are doing and that countries are doing to protect health workers. This is a priority of WHO's beyond the pandemic, but is a top priority of WHO's to protect health workers. We have guidance that is out around infection prevention and control, so how they can care for patients safely and the type of precautions that are needed depending on the type of care that's given. Our supply chain task force has worked very hard to ship PPE to 172 countries in all regions. Millions of respirators and medical masks, face shields, gowns, gloves, goggles. We've issued trainings for infection prevention and control to make sure that all health workers know what this virus is, know how it is transmitted, know what are the proper infection prevention and control measures that they can take. But we do need to ensure that health workers are equipped with the right PPE. And I think just lastly, we do need to do more to make sure that the right conditions are in place for health workers, that they have adequate rest periods, that they have psychosocial support. What health workers are going through is incredibly difficult, and we owe so much to them. And I think just lastly, we owe the respect to them, and there should be no stigma attached to the life-saving work that healthcare workers do.
Thank you very much, Dr. Maria. We have also in the room Dr. Bruce Aylward. He's the Senior Advisor to the Director General. He leads the ACT Accelerator, and he has something to add. Bruce?
Thank you to Fidela, and thank you especially, Gabrielle, for raising this important issue of just the stress that the healthcare workers and care workers in long-term facilities continue to be under in this crisis because we cannot give it too much attention, quite frankly. And I think Maria has done a wonderful job laying out all the things that we're trying to do collectively through the health sector, the health organizations, to try and ensure they have the tools, the training, et cetera, to take care of themselves. But I think what we have to remember, Gabrielle, when you ask what else we can do, is going back to what the Director General said in his opening comments. The single most important thing we can do is to collectively change our behaviors in the ways that are going to reduce the intensity of transmission, reduce the cases, and reduce the pressure on the health system. At the end of the day, that is the most important thing we do. We will look to our political leaders, we'll look to our health leaders to help address these issues, but we also have to look to us collectively, the general population, how we choose to work, how we choose to live, how we socialize. These are the important things that drive transmission. We've got to ensure we maintain the distance between people, the masks and the other public health interventions, because ultimately that's what's driving transmission, that's what's putting the pressure on the healthcare system. But like you emphasized, most importantly, behind that system of people, right? It's the healthcare workers, the nurses, it's the cleaners in the facilities, it's the physicians and so many others who work in these facilities that pay the ultimate price for the choices we make as individuals in terms of doing our part to reduce transmission. That is the most important thing we can do to help.
Thank you, Dr. Bruce Aylward. We will go now to Agnès. I was told the technical problem is solved. Agnès, Agence France Presse. Agnès, can you hear me?
Yes, I can hear you.
Oh,
do you
welcome,
hear me?
Agnès. Just ask your question.
Okay, great. I will ask it in French. D'après les médias suisses, les chiffres ont montré qu'il n'y avait pas de surmortalité liée au coronavirus pendant le premier semestre de l'année. La situation semble être différente dans d'autres pays de la planète. Est-ce que l'OMS dispose de statistiques qui montrent une surmortalité depuis le début de la pandémie? Et est-ce qu'il y a des différences régionales?
Thank you. Agnès, Dr. Maria?
I can begin, and maybe others want to jump in. So you highlight a very important aspect of a pandemic or any emerging pathogen as this pandemic evolves. There are deaths that are associated, that are counted, that we know are associated with COVID-19 from infection and are tracked in real time as they occur. There are ones that we will be identified as we retrospectively look at, we go back in time and we look at deaths. And there are systems that are in place in several regions and several countries that are looking at excess mortality. The one that I'm most familiar with, and there are others, is the one that's in Europe. That's the Euro-MOMO project, which is looking at excess mortality over time. And as you point out, there are some variations in excess mortality by country. I think it's too early to make conclusions about this because this is something that is ongoing. But I think it is important to recognize that deaths from COVID are likely to be undercounted at the present time. But countries are working very hard to better understand this. We do also need to be looking at other causes of mortality that are occurring during the pandemic because people have not been able to access the care that they need. So it is really critical that we get essential medical services and life-saving services back online so that people who need the care that they need can receive it and can receive it safely. And so that is something that all countries are working very hard on. We are working very hard on to support countries to be able to do. But I think we will see some differences in excess mortality, and we are tracking the systems that are currently in place that are collecting that information.
Thank you, Dr. Maria. Dr. Bente Mikkelson would like to add something. Please go ahead.
Thank you. Thank you very much for the question. And as Dr. Tedros said, we have had several surveys which show that we have major disruptions in the case of non-communicable diseases, cardiovascular diseases, cancer, diabetes, and respiratory diseases. So far we have comorbidity studies from single countries, and we are working on this also at a global level. So of course, it will be very important to trace what you're actually saying, because we really need to know if this will again dwindle the achievement of the SDG 3.4, namely to reduce the mortality from non-communicable diseases. So we don't know this yet, but from studies we know, and the good thing is that the majority of countries have actually now started to register comorbidities in their hospitals. So we know that, for example, in Mexico, diabetes were the most frequent comorbidity in the registered deaths for COVID. And we see other figures like in Italy, among those dying in hospitals, we see 67% of people living with hypertension and 31% living with diabetes. So this is, of course, very important both for the current situation, but also to understand the picture and be able to close these gaps with the guidance that WHO can give. Thank you.
Dr. Bruce?
No, Agnes, you raised a really important point about this excess mortality data. And as Maria laid out, many countries do track excess mortality, not all countries, so we don't have data from all over the world. And as Maria said, it's actually tracked differently in some countries, so we don't have exactly comparable data. But what we do know very, very clearly is that there has been more mortality during this period than the numbers from COVID-19 alone tell us. And that's extremely important. Some of that excess mortality is probably COVID disease that was not recognized or reported, but then it's also telling us that this incredible impact on the health system that Gabrielle asked about earlier is having a real cost in terms of human lives. And this all emphasizes the importance of the measures that the Director General has just emphasized day after day after day, because there's a real cost in human lives that go beyond the numbers that we're seeing in the COVID numbers alone.
Thank you all for these answers. We will go now to India to ask Aziz Ahmed from Hello Mumbai. Aziz, can you hear me? Please unmute yourself and ask your question. Aziz? I was told he's no longer online. If not, we will go to Anna Pinto. Anna, can you hear me?
Yes.
Hi, Anna. Just ask your question. Thank you.
Okay. Earlier this week, the president of Brazil, Jair Bolsonaro, was approached by a citizen who asked him not to deploy vaccines against COVID-19 in the country because, according to him, and I quote, vaccines are dangerous. And Bolsonaro replied to him that the government will not force anyone to get vaccinated. My question is, I'd like to know what is the WHO message for people who believe that vaccines are dangerous, and what can be done to counterbalance anti-vaxxers movements and disinformation? Thank you.
Thank you, Anna. I believe this question is for Dr. Soumya Swaminathan, our chief scientist. Soumya, you have the floor.
Thank you, Fadela, and thank you for that very important question. I think this is really a topic that everyone around the world is discussing today. I think the first thing to remind ourselves is that vaccines are life-saving interventions. And if you think about diseases like smallpox, like polio, like measles, that used to kill hundreds of thousands and maim millions of people around the world, it's thanks to vaccines that we don't see those diseases today. So we've forgotten what smallpox is like. We've forgotten what polio is like. We've forgotten how measles used to kill millions of children, still does kill hundreds of thousands of children, unfortunately, around the world, despite the fact we do have a very safe and effective vaccine for measles. So we have to put in perspective, vaccines and what they've done for humanity when we start thinking about COVID vaccines. We're at an early stage of development. No doubt that there's been an unprecedented speed of development of COVID vaccines. We've never seen anything like this before, and that's because of advances in science and technology, and also the fact that there are now platforms that have been developed because of investments in the last several years, which make it possible for companies and academic groups to just take the new virus sequence and put it onto an existing platform, which has already been tried and tested for other diseases. And this is part of the reason why we had a phase 1 trial of one particular vaccine 66 days after the first genetic sequence of this new coronavirus was made public. Now, having said that, vaccines still need to go through phases of testing. They need to go through lab testing, followed by animal studies, followed by human trials, starting with very small numbers of people to test safety, moving on to what we call immunogenicity studies, where we look for the development of protective antibodies and other immune responses, which we think are signals. But eventually you need phase 3 trials, which actually look at reduction of disease in the group that's vaccinated compared to the group that's not given the vaccine or is given a placebo. And this happens in tens of thousands of people who are also followed for safety signals. So no vaccine is going to be mass deployed before the regulators are confident and the governments are confident, and that WHO is confident that these vaccines have met the minimum standards of efficacy and safety. We have a very elaborate and thorough process where we look at all the criteria, the qualities of a vaccine, and whether they have been met before we will make any kind of recommendations, either on emergency use authorization or on a general licensing or authorization for use through pre-qualification programs. We have an independent group of experts, the SAGE, the Scientific Advisory Group of Experts on Immunization, that makes recommendations. Again, it's a globally recognized independent group of experts that will look at the properties of an individual vaccine and the data from the trials before they'll make a policy recommendation. So I think we should reassure the public that vaccines that are recommended for use by WHO and by the national regulatory authorities would have passed the minimum standards needed. We've also heard very encouraging statements from a number of the vaccine developers and the heads of those manufacturing companies that they will abide by the standard guidelines and rules for development of vaccines. So there needs to be, I think the questions that people are posing means that there is a need for more information sharing. There's a need for more transparency, for more education of the public on vaccines in general, and then on COVID vaccines in particular. Thanks.
Can I add?
Yeah, Dr. Tedros, please.
Thank you. Thank you, Fadila. I think Soumya had said it all. Just want to stress a bit. I would like to assure the public that WHO will not endorse a vaccine that's not effective and safe. So that's one. And second, as she had said, vaccines have helped in eradicating smallpox. Then almost on the verge of eradicating polio. But I would like to remind the world how we used vaccines to defeat Ebola in northern Kivu, eastern DRC, where the Ebola outbreak situation was very much complicated due to security. As you know, North Kivu is a place where more than 20 armed groups actually operate, and it's with the help of vaccines that we were able to stop or end the Ebola epidemic in northern Kivu in eastern DRC. So for people to understand the power of vaccines, it's better to see it's the track record of many of the vaccines we used in the past several decades and even in the recent past, as I said, in eastern DRC. So going forward, vaccines on COVID-19, we have a good number of promising ones. They will only be used when they're found to be effective and safe. That's what I would like to assure the world. And as Soumya said, this will be done by WHO and local authorities. As to the anti-vax movement, they can build narratives to fight against vaccines, but the track record of vaccines tells its own story. And people should not be confused by a movement, anti-vax movement, but they can have a look for themselves on how the world actually used vaccines to reduce under 5 mortality, to save children, and to have successful eradication of diseases like smallpox. So just please go to the track record of vaccines and have a look for yourselves, especially parents. Have a look for yourselves and see how vaccines actually change the world. And that's why we have this famous saying, vaccines actually affect adults. Our children will be healthy adults when we use vaccines. And for COVID, we are hopeful that we will have one so that the world can get back to normal. Thank you.
Thank you, Dr. Tedros. We will move now to Simon Ateba from Today News Africa. Simon, can you hear me? Simon? Second attempt.
Yes, I can hear you.
Simon, we can hear you.
Yes,
please go ahead.
Yeah, I can hear you. Thank you for taking my question. This is Simon Ateba from Today News Africa in Washington, D.C. Yesterday, WHO Africa said virtually all African countries, all 54 or 55 African countries, have expressed interest in COVAX, the groundbreaking initiative to provide almost 220 million doses of vaccine to Africa. I would like WHO to give us an update on what the next step is and what will be the contribution of each African country to take part in COVAX. And also to ask WHO if 220 million doses of vaccine for a continent that has 1.2 billion people is enough. Thank you.
Thank you, Simon. We will start with Dr. Bruce Aylward. Bruce?
Thank you, Simon, and thank you for emphasizing the importance of the landmarks that we passed this week in the battle against COVID and getting our ACT accelerator up and operating. As you highlighted, this week we passed the landmark by the 31st of August. We were asking countries to confirm their intention to participate in the COVAX facility, and as the Director General highlighted, we were delighted to hear that 78 high and upper middle income countries will be joining with the 92 countries of Gavi and that will receive support through what we call the advanced market commitment, for a total of now 170 countries that will be part of the ACT accelerator. The African continent has been a huge contributor to the work of COVAX. As some people on the call will be aware, there have been a number of important partners that we work with in terms of trialing vaccines and studying vaccines, also in terms of planning how they would be rolled out and operationalized over time. Also in the very design of the COVAX facility, we've had a number of big
Yeah, sure.